Medurstand. Understanding Medicine.
Professor Aziz Rehman here. In our series of lectures on Introduction to Clinical Medicine, this is part 6. And today we're going to cover examination of gastrointestinal system or GIT. Now let me give you a reminder that these are lectures which cover the theory part, and I'm going to give you just the outline of the clinical examination, and this will be followed by actual demonstration of clinical methods on bedside. And please watch those videos also to have a complete comprehension of these methods. Now, I think examination of gums and teeth may be included in general physical examination, but if you're asked to start the examination of GIT, then I believe you should start with examination of oral cavity. Now that of course is part of GIT. Oral cavity, you would examine the health of teeth and gums and anything else. I think the basic technique of examination is that you learn what is normal, and for that you will have to examine multiple patients. Once you know that this is normal, then whatever is not normal, that you make a note of that and describe in your case history. So after examination of gums and teeth, you would go to the proper GIT examination. And of course you need to take consent. Consent is very essential. It doesn't have to be written consent. You just explain to the patient that this is what you're going to do. Of course, the fact that patient has come to you is like kind of consent, but then you take consent at the beginning. And I think whenever you do some special method, like you examine the genitalia, you examine the breast, you expose the chest, then you have to take additional consent. And I think one way of doing that is just you tell the patient that you are going to do this, and then of course if patient has any objection, patient will tell you that I don't like this, I will not allow you to do this. Now first of all consent, then proper exposure. Now what is meant by proper exposure? By proper exposure I mean not too little, not too much. Now when you examine through the clothes, then you might miss some subtle abnormalities, right? But at the same time, we have to respect patient's privacy, patient's autonomy, so we would not like to expose the patient unnecessarily. Now, whenever you examine sensitive parts of the body, I think it is best to cover the rest of the body and expose that part which is to be examined. And once you have done that, then you cover that part and examine the rest of the body. So that is the proper exposure. And of course you need a female chaperone. If you are examining a woman, then you definitely need a chaperone. I'm not sure what is the standard if a woman physician is examining a male patient. I think again you probably need a chaperone. Now examination of inguinal areas is included in the examination of GIT. Because there could be a separate genitourinary system also, but in internal medicine, in typical undergraduate and postgraduate teaching in Pakistan, we include genitalia as part of GIT. Of course, they have different functions and their diseases may also be different, but they are to be examined with abdomen. Of course, that part needs to be exposed only when you're examining that part. So typically examination of GIT also consists of inspection, that is just looking at the abdomen from front, from sides and maybe from back also, and looking at the genitalia. Then palpation, you first perform superficial palpation and then you examine different parts by palpation. Then percussion, very important. Percussion has got very useful role in the examination of GIT. I think you need to master your techniques of percussion on GIT. Then auscultation. Auscultation has relatively less role in GIT as compared to respiratory system and cardiovascular system, but definitely there is some role. So let's first take up this inspection. In inspection, you would just see the normal shape, the shape of the abdomen. Depending upon your build, your abdomen could be flat or could be scaphoid or could be prominent, protuberant. So that is because of your body weight. But if there is any other abnormality in shape, that you would like to make a note of that. Like for example, abnormal protuberance in the flanks, or abnormal protuberance in the center, or too much distension. And one can tell actually what is the cause of distension. Now, distension due to ascites, distension due to intestinal obstruction, and distension due to obesity, they all have different appearances, and you need some experience to be able to differentiate between them. Then see if there is any distension. Distension could be due to ascites or could be due to distension of intestines or some other massive organomegaly. Or then you examine abdominal veins. You are just actually looking at the abdomen, and all these things you can note. On abdominal veins should normally not very prominent. You can see them, especially in good light and in a fair person, but they should not be very obvious. If they are, that means there is a problem. And there could be superior vena cava obstruction, there may be inferior vena cava obstruction, or there may be portal hypertension. In some cases, they may be normal. Okay, so abnormal distension of vein is like to be noted, and there could be vena cava obstruction, either superior or inferior, and there are some specific methods to differentiate between superior vena cava obstruction and the inferior vena cava obstruction, and I will demonstrate those methods later. Then in portal hypertension, there may be a specific pattern of venous distension called caput medusae. Then abnormal protrusions, somebody having massive splenomegaly, you could see a protuberance on the left hypochondral region. Somebody having a liver mass, you may be able to see a similar protrusion on the right side. A hernia may be seen as protruding and pulsatile. So I think all these things to be noted. Then peristaltic wave. In a normal healthy person, you can't see peristaltic wave. So if somebody has intestinal obstruction, then peristaltic activity may be increased and you can actually see them. And especially if the patient has got wasting and cachexia, then you may be able to see those peristaltic waves. So these are some of the things you can examine and you can just note on inspection. Of course, any other significant change like any pigmentation, scarring. Now, a scar on the abdomen would mean a previous surgery. What is the relevance? That could give you very important clue to the diagnosis. So any previous scar, any wounds, any incisions, any pigmentations, any growths, they are all to be noted. So whatever abnormal, I think very simple, whatever is not normal, you just make a note of that. So this was briefly inspection. Now let's move on to palpation. I think it's human nature that whatever you see, you then feel it, try to feel it to be more sure and to just confirm your finding on inspection. Now, I think first of all, you do what is called superficial palpation. Now, I've seen doctors doing superficial palpation, which is very superficial. I think that has got no purpose. It is not to be very deep, but not very superficial either. So you need to press the whole abdomen very gradually, starting from say any part, right iliac fossa, then work your way up, then going to the starting from the left iliac fossa, go upward, and then make a round, go to the right side, come down, and then go to the center. The purpose of this superficial palpation is to find out if there are any areas of tenderness. Typically, if when you do the examination, first you actually ask the patient if there is any area where there is tenderness or pain. So that part is typically examined at the end, so that if patient gets pain, patient would do the guarding. Patient will actually make the stomach very stiff, and then rest of the examination may not be possible. So typically the area that hurts is to be examined at the end, and on the superficial palpation you determine if there is any area of tenderness, and you also have rough idea about the organs inside. But then you examine different organs one by one. Then liver and spleen. You know, in the abdomen we have many organs, but liver and spleen are very important organs which are palpated every time we palpate the abdomen. So liver and spleen, kidneys are normally not palpable. They are too deep and the back, so they are not normally palpable. Even liver is also not normally palpable. You just feel the lower edge. Spleen is normally not palpable. In the pelvis, normal pelvic organs in women, uterus is not normally palpable. But if there is enlargement of uterus or ovaries, or there is a mass in the abdomen, they should be palpable. And if there is intestinal mass, if there are lymph nodes, if there is mesenteric mass, and if there is aortic aneurysm, they're all to be palpated. Of course, I think remember that thing, whatever is not normal, I think that is to be noted. So liver spleens are very important, and you will be in the examination asked to examine the spleen or examine the liver. So I think I'll give some more detail on these two. Then bimanual palpation. Kidneys are not palpable, but if you do bimanual palpation, and this method I will demonstrate with bimanual palpation, with the left hand, you put your left hand behind the lumbar region and push that part forward and try to feel the abdomen, and if there is enlargement of kidneys, you may be able to palpate them. Now, kidneys are enlarged in some condition if there is a large kidney tumor, but more importantly, polycystic kidney disease. There may be bilateral enlargement of kidneys. Then you come to the inguinal region, you expose this part. Before that, you just had exposed the chest just above the costal margin and just up to the inguinal region. So I think that part is examined, and when you come to the inguinal region, you expose it further down, and then you see that part, and then you palpate that part. I think to make it convenient for the patient, inguinal region can be examined, the inspection and palpation can be done at the same time. So it doesn't make any point first to expose that area to inspect and then cover it, then you into palpate. When you come to the palpation, you expose that area again and then you palpate it. I think this part should be inspected and palpated at the same time. Now remember, this inspection, palpation, percussion, auscultation sequence, this is, I think, made for the sake of description. In real practice, you don't actually have to exactly follow this pattern. As sometimes we just do inspection and we palpate the same thing at the same time. Now, for example, this technique would mean that you examine, you inspect from the front, from the side, from the back, and then you palpate from the front, from the side, from the back. But for the sake of convenience, you could do inspection and palpation the front when patient is lying down, and then you ask the patient to sit up, and then you do inspection and palpation from the back at the same time. So I think depending upon the situation, you could adopt accordingly. So examine the inguinal regions. For that, you would see if there are any masses, typically soft masses. Typically these masses are pulsatile. With cough they come out, and when you press them gradually they go back. So these are actually signs of hernia. And there could be other masses also. There could be inguinal lymphadenopathy. That of course will not be very soft. Depending upon the cause, it may be hard or firm, and they would of course not be reducible, and they may be tender. And there could be some other problem in this region. So that was the palpation. Now come to the percussion. Percussion, I think very important. You need to learn the technique of percussion on abdomen. Now you first percuss the whole abdomen. Now what is actually percussion? When you tap the abdomen, typically you put one hand on the abdomen and the other hand you tap it like this. With this, the area under the finger would actually produce certain vibrations, and that vibrations are converted to sound. The sound quality and the pitch of that sound can tell you what is the nature of organ underneath. Now with experience you will learn that there is what is called dull tone. For example, when you're percussing on the liver, since the liver does not have any air, the tone that it produces is called dull. Now when you are percussing on a viscous which has got air, like stomach with air, the type of tone is different, that is tympanic. Then sometimes you may have resonant. So there are different types of resonance that will be described later, but first you percuss the whole abdomen. In a normal person, since abdomen contains intestines and intestines have both air and fluids, so you would have kind of mixed tone, not too dull and not too resonant. So that you have to learn. And typically in the center of the abdomen you have more resonant tone as compared to phalanx. Particularly true if somebody has ascites. So first percuss the whole abdomen and then you go to different areas. If there is ascites, you may have what is called shifting dullness. Now this is the technique. I'll just explain to you the principle now, but we'll give you the actual demonstration. If somebody has ascites, ascites is presence of free fluid in the abdomen, and that will first fill up the paravertebral gutters and then it will float over the spine. So when it is filling paravertebral gutters, this sign called shifting dullness may be positive. You start percussing from the center to the both sides, maybe right or left, and once you go to the flanks, you will notice the change in the tone. In the center of the abdomen, there will be a resonant tone. Once you go to the side, then you will note that the tone has become dull. This is because there is fluid on the flank. You go just 1 inch further and then you ask the patient to take a turn to the opposite side, right? If you are percussing the left side, you ask the patient to take turn to the right, and then after a few seconds you again percuss and you will notice that the area which was initially dull has become resonant. Now you then come back toward the center of the abdomen, then you will notice that the center of the abdomen, which was initially resonant, has now become dull. So in other words, the shiftness, this dullness has shifted from the phalanx to the mid-abdomen, right? So this shifting of dullness is because of something which is producing dull percussion note but can shift also, and what can shift is the free fluid in the peritoneum. So typically shifting dullness is taken as a sign of free fluid in the abdomen, that is ascites. Although sometimes if there is a large amount of fluid in the intestine, that can also exhibit this sign, but it will not be that prominent. Okay, so shifting dullness may be done on one side or both sides to demonstrate that there is something that shifts and that something is fluid. And then you build up the differential diagnosis of ascites. Then there's something called fluid thread. Now with this you put your own hand on one flank and you tap the other side like this. And if there is fluid in the abdomen which is sufficient to fill both paravertebral gutters and is also sufficient to float over the spine, then the fluid, there will be a wave, like a wave will be created, and it will go to the other side, and with the other hand you can feel that wave. Now you need little experience to be able to elicit this sign, and remember this sign is much less sensitive than shift and dullness. So you will always have shift and dullness positive before fluid thrill is expected to be positive. Now sometimes this wave it could actually transmit through the abdominal wall, so to block that you can ask the patient to put the hand in the abdomen, on the abdomen, or you can ask you have to ask the patient or the attendant to put the hand on the abdominal wall to block that wave going to the other side. I think you can play a little trick here. If you are sure that there is no shifting dullness and you're asked to do fluid thrill, and I'm sure if there is no shifting dullness, fluid thrill will also be negative. So I think you can play that trick. If there is large amount of fluid and shifting dullness positive, only then fluid thrill may be positive. Both indicates presence of free fluid in the abdomen, but if there is very small and you're not very expert, then you can miss actually. Both the signs may be negative, and then you will be able to pick up this fluid on ultrasound. Upper border of the liver may be percussed. Now we are discussing percussion because upper border of the liver is behind the ribs. You cannot palpate that part. So to have an idea about the liver size, we palpate the lower part, but we percuss the upper border, and then we determine the span. So typically you will start percussion from here in the intercostal spaces. You come down and then determine the level of upper border, right? The upper border may be shifted, or maybe is shifted maybe because of the displacement of the liver, or maybe because of the enlargement of the liver. Now in emphysema, for example, upper border of the liver may be displaced downward. In right-sided collapse, upper border may go up, but in hepatomegaly, liver upper border will go up, at the same time lower border will go down. So this is how we differentiate between actual hepatomegaly and just the displacement. Then percussion of lower edge of spleen. Now when would you do this? You know, spleen is present in the abdomen below diaphragm on the posterior side. Now normally spleen is not palpable. It has to enlarge to significant size, maybe 2.5 times before it becomes palpable. So before it becomes palpable, the only way to pick up splenomegaly is by percussion. Now this area, the area of the lower chest cage, this part is called Turab's area. Now in splenomegaly, which is not sufficient to be palpable in the abdomen, you can determine the presence of dullness in this area. Now if this area is dull, that might indicate presence of splenomegaly. Okay, so percussion has got a very important role in the determination of splenomegaly if the spleen is not too big, 2.5 times or less. Actually, my reflex is when I am palpating, I said earlier that you don't have to follow this sequence. When I am palpating for the spleen, due to history or something, I am expecting splenomegaly or want to rule out splenomegaly, I am palpating spleen. If I don't feel it under the costal margin, the next step I do is to ask the patient to turn to the right, and then I do the palpation again. But if still not palpable, then I do percussion to make sure that it is not enlarged. Position of the diaphragm can also be determined by percussion, but this is not, I think, very commonly done test. Now this was the percussion. Now let's move on to auscultation. In auscultation, I think we can auscultate for vowel sounds. When we auscultate, we typically put the stethoscope on the right side of the abdomen, somewhere in the middle of umbilicus and right like crest. So I think somewhere in the middle, because this is the area where you would have representation of small intestine and large intestine. Now, what do you expect in a normal person? You would have bowel sounds present, but with experience, you would know that this much is normal. If bowel sounds are increased in intensity and in frequency, this might indicate intestinal infection or intestinal obstruction. And if intestinal sounds are absent in an appropriate patient, in a normal person, you might not have intestinal movement for several minutes sometime. So if you do not have any abdominal sounds at all for several minutes and you are suspecting paralytic ileus, so this would actually support the diagnosis of paralytic ileus. That means there is no intestinal movement at all. That is paralysis of abdominal sound. Sometimes these sounds may be so loud that you can hear them even without stethoscope. We call them borborygmi. They're not necessarily indicative of an abnormality. Sometimes a normal person could have borborygmi occasionally, but it might indicate intestinal obstruction also. Then you also auscultate for the renal bruit. Now this you would do in cases of hypertension where you expect renal artery stenosis. So you have some idea of the anatomical location of renal arteries and you put your stethoscope there and see if there are any systolic and diastolic murmurs. So this would indicate that area of renal bruit. Sometimes there may be aortic bruit also. So in aortic stenosis or coarctation, you may be able to pick up these aortic bruit. Normal healthy person do not have these bruit. This is called bruit, not bruit. So this is called bruit. T is silent, and this is abnormal sound coming from the vessel. That is bruit. So this was auscultation. I think now I'm going to spend some time on the differential diagnosis and the causes and the differential diagnosis of hepatomegaly. First of all, just a recap of what we discussed, how we determine the presence of hepatomegaly. We specifically palpate the lower border and there is a method. The method is you start palpating in the right iliac fossa and gradually move upward with the medial edge of this finger, and you palpate it and you press it and then you make this movement and see if the edge is palpable. And with every movement you ask a patient to take an inspiration, and because with inspiration diaphragm moves downward and you may be able to feel the liver edge. So once you feel the liver edge, then you determine its position. How many fingers or how many centimeters or how many inches below the costal margin. Traditionally we measure it with the finger breadth because fingers are always with you. So that's convenient, but there may be a point in measuring it with centimeters and inches to be more uniform because finger size could vary. So you describe it, the lower border palpable 3 fingers or 2 fingers below the costal margin, right? And then you go to the upper border, percuss it, and then you determine its position exactly. For that you need to first determine second intercostal space, which is against the sternum manubrae, and then you come downward and you count which intercostal space your upper border of the liver is. Normally maybe it is in the 5th or 6th. So you then measure the distance between the upper border, which we determine by percussion, and the lower border, which we determine by palpation, and then you measure the total span. The normal span is like 12-13 centimeter. It may be little less or little more depending upon patient's body size, but if it is very big, then of course it is abnormal. So once you determine hepatomegaly, then you, I think, have to determine several additional things. What are those? First of all, I think this I have already described, percuss upper border and measure span, and you, I think, make a note of consistency of liver. Normal liver is not palpable. If you can palpate the lower border, it should be soft because liver is soft and it could be firm in certain diseases, like in cirrhosis it may be firm. or it may be hard. Typically in malignancy, liver may become hard. Okay, so not only you see if there is palpable or not, you see if it is soft or firm or hard. Then you look for tenderness. In a normal person, if you press gently, I say gently, if you press on the liver on the gently, there should be no pain or discomfort. But if there is inflammation in the liver may become tender. Or if the liver is congested, liver may become tender. I'll give you some differential diagnosis in the next slide. Irregularity. Normally the lower border is very, very smooth. There is slight notch-like effect, but between left and right lobe, but you don't see that irregularity. If the lower border is clearly irregular, it could indicate cirrhosis or it could indicate metastasis. Then pulsation. Normal liver may exhibit slight pulsations because venous pulse can be transmitted back to the liver, but not, I think, appreciable on normal palpation. But if liver becomes pulsatile, particularly if liver pulsates with every systole, this might indicate a tricuspid regurgitation. Now let me give you the differential diagnosis of hepatomegaly. Normally liver is here present in the right hypochondrium. It is mostly present under the diaphragm, actually above costal margin. Normally you just feel the costal margin when patient takes an inspiration. In majority of the cases, you don't feel the lower edge when patient is in the phase of expiration, and mostly liver is here. And maybe when it passes to the left lobe, you can feel the left lobe in the epigastrium in some cases. But when it enlarges like this, it will go upward. The upper border will move upward, so that you will determine on percussion. But the lower border will move downward, that you can determine on the palpation. So further things, first is to determine if there is hepatomegaly. Then many other things you have to determine. Say liver is tender, and then you would think of possibilities like acute viral hepatitis or liver abscess. Luckily, liver abscesses are now have become less common, but they used to be common abnormality. They still exist. Liver abscess, amoebic or pyogenic. Then in heart failure, right heart failure due to right-sided heart disease or due to copulmonale or congestive cardiac failure, you could have a tender liver. There may be other causes also, but these are important ones. Then if liver is firm and is also somewhat nodular, I think you would consider the possibility of cirrhosis. Now once you determine the presence of cirrhosis, of course you will then try to find out what is the cause of cirrhosis. In our country, it is by default viral, typically hepatitis C and hepatitis B, but it could be due to other causes like alcoholic abuse or hemochromatosis, hemosiderosis, things like that, and some other disorders. Cirrhosis may be present. Sometimes heart failure can also cause cirrhosis. If liver is hard and irregular, large, hard and irregular, this is typical feature of malignancy, right? So of course you cannot miss, you cannot determine small malignancies deep inside the liver, but if liver has become enlarged and hard and is irregular, patient is likely to have either a big primary liver cancer or more likely a metastasis coming from any other organ like colon or any other organ. Then if liver becomes pulsatile, it may indicate tricuspid regurgitation. All right, so I think these are some of the causes of hepatomegaly. There are actually many, but I would be happy if you come up with just a relatively short list like this one. Now let's talk about splenomegaly. Spleen is normally present in the abdomen, but in the dome under the diaphragm, and is not normally palpable. Actually, it is to be enlarged many times, 2.5 times to be palpable. So once it is enlarged, it may come downward and forward, and then you may be able to feel this. And there's a typical notch, because in traditional teaching we always discuss how to differentiate between a splenic mass or some other mass in that area, like colonic mass or renal mass. So this typical notch, once you feel this notch, every person with splenomegaly is likely to have this notch. Now, if you can feel that notch and familiarize yourself with that notch, then you can say for sure that whatever you're feeling is actually splenomegaly. So I think, and then the differential diagnosis, splenomegaly may be mild when it is not palpable. It is enlarged, only detected by percussion, but it could be moderate if it is palpable below the costal margin, or it could be massive when it goes downward and to the right. It could actually occupy the whole abdomen. In some cases, there may be typically massive splenomegaly. In some storage disorders or in some myeloproliferative disorder, chronic myeloid leukemia or myelofibrosis, there could be massive splenomegaly. There may be lymphoma in the spleen, there could be metastasis, there may be some cysts in the spleen, so spleen may be massive. Typically, the differential diagnosis of mild, moderate, and massive splenomegaly is built up differently. Then movement with breathing, because spleen is in touch with the in contact with the diaphragm, so with every breath, with every inspiration, it should move downward. So when we are palpating the spleen, we ask the patient to take an inspiration and we see if it moves downward. And notch in lower border is very, very characteristic. Without notch, I think you cannot be sure that whatever you're feeling is actually splenomegaly. Then tenderness, like liver, spleen can also be tender, like in endocarditis or tuberculosis, spleen may be enlarged and tender, or in sometime it may be irregular, like in metastasis, the spleen may become irregular. So I think this is some of the characteristics you study when you examine spleen. Pulsation may also be present. Now let's discuss the differential diagnosis of splenomegaly. I think chronic liver disease. Now please note down, in chronic liver disease, spleen is usually enlarged but usually not palpable. Why so? Because it is not massively enlarged. It is enlarged but not massively. So it may be palpable in some cases. In good percentage of the cases it is palpable, but it may not be palpable. Why? Because it may not be enlarged by 2 to 2.5 times, or the palpation may be difficult, but the palpation of spleen may be difficult in the presence of large ascites. So then you rely on percussion, right? In some cases it may be palpable. A palpable spleen in cirrhosis would indicate significant portal hypertension. Infections, all kinds of infections can cause splenomegaly, like some viral infection like infectious mononucleosis or endocarditis, bacterial infection, endocarditis, brucellosis, tuberculosis, malaria, some parasitic infection. There are many infections where you may have splenomegaly. Then myeloproliferative disorder. This includes 2 or 3 conditions. It includes chronic myeloid leukemia, it includes myelofibrosis, it also includes essential thrombocytosis. In all these conditions, spleen may be massively enlarged. And storage disorder, which typically are seen in children, there may be splenomegaly also. In some hematological disorder like thalassemia, there may be splenomegaly. In hemolytic anemia, there may be splenomegaly. Actually, there is a long list. I cannot cover all those causes here. So I think we're coming to the end. One common finding in examination of GIT is ascites. Ascites itself is not a disease, it's a condition, and you have to find the disease behind. So you have to know the causes of ascites. I think that by default, if somebody has ascites in our country, by default, the etiology is likely to be cirrhosis of liver. Of course, you will elicit the signs of cirrhosis, you will take history, and mostly you will find out that this patient has got cirrhosis of liver due to hepatitis C or hepatitis B. So ascites would also mean that the cirrhosis is decompensated. For several years, you may have cirrhosis without ascites, but if there is ascites, that would mean a patient has got a decompensation and there could be some problem related to this decompensation. Tuberculosis of abdomen. Now, I think I would consider tuberculosis only after ruling out cirrhosis. Cirrhosis is so common that even tuberculosis is considered to be common in Pakistan, but still I would first rule out cirrhosis on clinical examination and maybe on labs, including including examination fluid before I consider tuberculosis. Tuberculosis can be considered in those patients who have some specific symptoms suggestive of tuberculosis, like whole abdomen is tender and patient has got history of fever, patient has got evidence of tuberculosis elsewhere, or patient has got a history of tuberculosis in the family or in the close context, and you don't find any evidence of cirrhosis. So think that will make the diagnosis of tuberculosis likely. But ultimately, I think you need to examine the fluid, tap the fluid, and make sure that this is exudate, and only then you can tell that this is not cirrhosis. In cirrhosis, fluid is typically transudate. In tuberculosis, it is exudate. And even in cirrhosis, when there is superadded bacterial infection, SBP, there could be an exudate-like picture. So I think the differential diagnosis is not very easy. One thing to make it further difficult, that you could actually have tuberculosis or infection on the background of cirrhosis. So you have cirrhosis and you also have tuberculosis and maybe some other bacterial infection. I think that makes differential diagnosis very challenging. Then malignancy. Malignant effusion is third in the list. If somebody has a known malignancy elsewhere, like prostate cancer or lung cancer, then I think anybody presented with ascites, you could immediately assume that this is malignant. But otherwise, I think you cannot entertain this possibility without examining the fluid. I think you could build up the possibility, but you can only be certain about malignancy after doing fluid examination. Then heart failure. Luckily, this is now becoming less common because we have effective treatment for heart failure, but a very, very long-standing right heart failure due to lung disease or due to heart disease itself, that could lead to what is called cardiac cirrhosis or cardiac sclerosis. There could be ascites and in some cases splenomegaly also. And in hypoproteinemia due to nephrotic syndrome, due to malnutrition, or due to intestinal disease, malabsorption, severe hypoproteinemia may also cause ascites, but this patient would also actually have anasarca. That means edema everywhere. So if you have ascites only, then you're likely to have one of these three possibilities. And then other cases, because I think no matter how long the list of differential diagnoses you develop, you are never complete, because there are so many diseases and there's so many situations. There is always another possibility. A good physician would be able to pick up the commonest abnormality, the most likely abnormality, but will keep room to accept any alternate, anything, because when we investigate the patient, sometimes we get surprises and something come up which we had never thought. Now we're coming to the end of this presentation. After you have done with the physical examination, if investigations are available, abdominal ultrasound is very, very commonly performed investigation. And in fact, some people would say it is the fifth method of examination. So after inspection, palpation, percussion, auscultation, you move on to doing ultrasound. Nowadays, ultrasound is becoming more and more available, and small handheld devices are available which you can use on the bedside. So literally, as a fifth way of examination, maybe you can use ultrasound. But if other imaging test is available, you like to see them. And if patients got ascites and patients undergone fluid examination, you like to review that. I hope this presentation was useful. I admit this was without the clinical method demonstration, because if I included them also it would become very long. So please join me in the clinical method videos on GIT to complete the module. So thank you. This has been Professor Aziz Rehman from Medurstand. Please join me in my next video. Thank you.